Interprofessional collaboration of medical physics. So we have three eminent speakers, Robert Jeraj, S.M. Krishnan and Eva Vizak. And each speaker has been given 25 minutes. I request the speakers to adhere to the time. I hand over the mic to my co-chair for a brief introduction.
Professor Jeraj, Robert Jeraj, yesterday he is just our one of the very esteemed faculty, and I think yesterday he has landed at Delhi, and he is working at USA, and I think without wasting our time, if Dr. Jeraj can tell a few lines about himself, that will be far better.
Okay, thank you. I'll be short and brief so that we can move on. Thanks everyone for not breaking for coffee and tea. I know that's a tough one, but I appreciate your passion to stay here. So I'm Robert Jeraj from University of Wisconsin, also University of Ljubljana in Slovenia. So I've been in medical physics for more than it looks like, and my main research interests, essentially, you'll see in my talk. So possibly focused on improving clinical decision-making and also understanding, particularly through understanding better cancer, tumor heterogeneity, resistance, etc. Hopefully that will be enough, so I can just go.
Please continue now with your presentation.
Yes. So I'll give you today a little bit of a talk that might be sounding a little bit puzzling at first. So why do we talk about reigniting the role of medical physics? And then I'll talk about sustainable futures, so kind of like blending a little bit my views of what I think where we should be going. But of course, we could not go anywhere besides really on today's special day, wonderful memory of Marie Curie. And here is one of the great quotes from her: "Have no fear of perfection, you'll never reach it." Which means that we shouldn't be perfect, but we should be realistic. Just brief disclosure. And I'll start with a brief history of medical physics. So as we know that the modern medical physics has started essentially with the discovery of X-rays, but something which is often forgotten is that there are a lot of very important discoveries that have happened on this path. We're all aware of, but we don't typically attribute them necessarily to medical physics. Like obviously discovering X-rays that led to CT and other first treatments, radioactivity, discovery of protons, nuclear magnetic resonance, and a lot of Nobel Prizes were given to medical physicists, at least those that we would like to claim on. Again, I'll just briefly go back to Marie Curie, and one of the reasons that I want to mention is that she got PhD in 1903, and this is the same year that she won the Nobel Prize. And I haven't found a record that anyone would win a Nobel Prize on the year that finished a PhD. So I think that's definitely something to look forward. It's also important to know that she was the first female professor of general physics. And that was a big thing at that time. And I think that's also very stimulating to see how it, even at that time, I think was really the, the power of spirit. That didn't matter whether somebody was a man or a woman that was awarded with the highest honors. So really something to be very proud of and also be very inspired by. So if we go back to Marie Curie's time, you see on the left-hand side, you see what was the imaging procedures with William Röntgen examining a patient. And then on the right-hand side, you see the first treatments that were done with X-rays. So I have a question for you. What is the major difference to what you see today? So if we go to the clinic, anyone wants to guess what's the major difference? We're still imaging with X-rays, we're treating with high-energy X-rays. There's one important difference. You know what it is? Nobody's wearing hats anymore. At least I haven't seen any doctors wearing big hats anymore, correct? So, of course, there is a little bit more to that. So if we go into modern clinic today, as you will see, we get things like image-guided radiation therapy, image-guided surgery. So when we can really combine way better imaging modalities with more advanced treatment modalities to really increase the precision of the delivery where we go. So medical physics has a lot to be proud of, and that was just a brief overview of what to be proud of. But is this really where we should just stop or continue? We've got a little bit of insights before from Dr. Jodel, very nice, and we'll have some parallels. And I promise that we didn't synchronize at all, but we do have too many parallels. So it must be something true about it. I mean, so we have to go back to say, what is medical physics? And medical physics is really the merge of two disciplines, medicine and physics. And of course, we're talking about engineering, but of course, engineering physics are both in the kind of like basic science that blend with a medicine. But if we want to see where we should go as a field, we should reflect on where medicine is going. And we heard about 4 P's of sustainable healthcare, but there's also 4 P's of medicine. And the first time that was kind of like promoted was by a former director of NIH, Dr. Elias Zerhouni, who basically put 4 P's, that the future of medicine will be predictive, will be personalized, will be preemptive, but will require participation from everyone. So, and I think those 4 P's are really important to look at where we should also be as a field. And the theme of this year's meeting is personalized medicine. So 10 years later, after he was giving this justification for the budget in front of the US Congress, there were a number of initiatives very important that were initiated in the US and across the world. For example, the Precision Medicine Initiative, the Cancer Moonshot. But what was the behind precision medicine? I apologize, I was not able to be here before, so I don't know how much you heard about precision medicine. But the precision medicine, one would say, well, you know, in radiation therapy, we are personalizing therapy in a very precise way all the time. But that's not really what precision medicine about is. It's not about like giving the dose that somebody is prescribing. It's actually choosing the right dose, it's choosing the right treatment to every individual. Why? Because if you give 2 patients identical treatments, they won't respond equally to the same treatment. Why not? Because their cancers are not identical. So this is at the core of precision medicine. So this is a very profound implications that it has. However, there is a little catch in that. And the catch is that when you go into more advanced disease, and typically medical physicists are not that much in advanced disease, but you know that cancer would promote into and go into a metastatic state. Every subset of disease is essentially has its own response. So the same way as how we see heterogeneity of response on per patient basis, we see a heterogeneity of response, even individual cancer, tumor, but also when we go in advanced states in every lesion separately. So this is very profound. And why is this happening, one would say? Well, it's all because of the cancer evolution. And if you think a little bit, how much have you been taught about cancer evolution? How much are you thinking about cancer evolution? How much do you take that in your daily activities into account? Well, but that's very profound property of the tumor. So what does this cancer evolution leads to? It leads to intrinsic resistance. And that's one of the things that you see, even like the radiation therapy, for example, many of you that are there, not all the tumors will respond the same. Not all the tissues will respond the same. So this is something what is called intrinsic resistance. But when you keep treating patients and insulting tumors with this evolutionary pressure-like treatments, that leads to the acquired resistance. So we're building resistance in the tumor cells, which that in turn, it leads to intra-patient and intra-lesion and inter-lesion heterogeneity. So this is very fundamental concepts that probably, while many of you have not really thought too much about it, but I really encourage you to think and start looking a little bit more into that. Why is this? Because that leads, as I said, to this tumor heterogeneity that can be both spatial, that the tumor will not respond through the same part of the tumor, but also temporal. It won't respond in time in the same way. Now, reflect back again and see, okay, what can medical physics do in that space? But before we go to this, let's look at what's a typical journey of a patient, say, with a prostate cancer. Not very different than like patients with a breast cancer. So initially, when somebody is diagnosed, the first line of therapy would be surgery and radiation, and that usually takes care for about 10 years. So nothing to worry about for the next 10 years. But then in prostate cancer, then the cancer typically would come back, And then the next line of therapy comes like so-called androgen deprivation therapy. So because a lot of prostate cancer is driven by the androgen, so it's like stimulated by hormonal, you get like hormonal type of therapies or something what's called also chemocastration. And then, however, the tumor is again smart because of this pressure, starts escaping this insult and blockade of the androgen pathway, and starts going into more metastatic, more aggressive state. So that takes a little bit about 2 to 5 years. But then starts spreading, becomes metastatic, gastric resistant, and that's really the tough fight that every patient has to fight, and every doctor has to fight. And that takes roughly about 1 or 2 years. Of course, this is just like on the average, so some are much happier, can live much longer, but some are so much less. But why is this important? So if you look at where medical physics is today, medical physics is just in this first initial bottom part for most of it. Radiation therapy, as we heard, 95% radiation therapy. But really, 95 of the fight, and also expands, about 90% of cancer expands, goes in the upper part of the pyramid. Where is medical physics there? It's not. Should it be? Maybe, not maybe. For sure it has to be there. And we'll have to go there. So how do we go there? So obviously there is too much that I can tell you. I've got like 25 minutes and not more, but I could talk for days and more. So I'll just give you a little snippet, just because they did see. One of the things that you've heard, a little bit of medical physics that's already happening, is when we go into the imaging. We know how important imaging is in any aspect, from diagnosis to treatment prescriptions to treatment responses aspect. But how is imaging currently mostly used? It's mostly used in a diagnostic way, with radiologists, nuclear medicine physicians looking at the scans and looking and said, okay, well, we see this and that. Or somebody has got a disease. That's a binary decision, yes, no. And you look at, okay, now look at these 2 scans. How would you describe them? How would you say how much there was change? How did individual lesions change? Can you quantify how many lesions are there? What's the total burden? So this is exactly the questions that no radiologist can give you right now, because it's just too complex. So what we need to do is to actually apply something what's called quantitative imaging. I hope many of you have heard about quantitative imaging. Well, where applies qualitative ways of qualifying imaging signal. And then we can do some tricks. We can fuse the scans, we can compare every lesion, and we can assess response on per lesion basis. So why is this important that we assess response on per lesion basis? I showed you earlier, we're talking about precision medicine. But there's no precision medicine when we didn't know for every part of the disease how it's responding, isn't it? So we need to do this. It's just absolutely necessary. And this is how, for example, we can get scans like there. When you see green lesions, the disease that's responding, the red part is not responding. But you see, this is like pretty amazing, isn't it? That you have in one patient, at some point, some disease that's responding and some disease that's not responding. And some that's great that you don't know what's happening, it's stable. So what the physicists can help with that, they can see what nobody has seen before. So what the physicians currently were just like, oh, whoa, we haven't really looked at this way. Of course you haven't, because nobody has given you this information. What also medical physicists do, they can measure it to the precision that was not measurable before. Why? Because we're used to measuring things. Physicists measure things, that's like the first thing you're used to. Or when like Physics 101, they'll teach you how to measure, how to assess uncertainties. How do we do it in imaging? We repeat the scans like you would repeat any measurement, and you get like, for example, limits of agreement to see what is the area, which is then the one where you can change, what's their uncertainties. And that can create, for example, response categories that go lesions that are like new, progressing, stable, responding, or disappearing. So this is like the scans that you will see also through the rest of the talk. So, and once we have this, we can classify the disease. And that is, for example, the red part, that's the bad part of the disease, that's kind of like escaping treatments, and the green one, which is a great one, that's the one that's responding, and something in between. Left-hand side, you see an example patient that I showed earlier. Some disease responding, some not. But if you do this, this is an example of over 100 patients, and each bar represents one patient's disease. You see only a few patients on the left-hand side are the ones